to Ken, and he'll take us away. And you're on mute. 1 second. There we go. Unmute.
And hello.
There we go.
Hey, fellow Zoomers. Good to see you all again. So tonight we're going to go through actually a lecture that was supposed to happen a long time ago, but thanks to COVID, it's kind of changed the schedule for a lot of things. We're going to be talking about total knee replacement tonight. And I'm looking for my stack here with my slides. Very good. So we're going to go through each of the a lot of different components regarding total knee replacement from the rehab perspective. So when you're talking with your surgeon, you're going to be talking about what type of knee replacement are you going to get. When you're talking to me, it's going to be, well, after they're done sewing everything up, what's it going to be like? So we're going to go through a lot of things here, and also some things about planning, about placement after you have your total knee replacement. Let's go ahead and go to the next slide. Just a little bit about myself. Usually when I do these lectures, I've been doing this for a while. Got my doctorate over at physical therapy, or Western University of Health Sciences physical therapy department there in 2010. When you see OCS for letters after a name, that's an orthopedic specialist. So there's a exam that you go through to get that. But my whole career I've been doing orthopedics and sports medicine, so seen a lot of total knee replacements, ACL repairs, things like that. So this is very familiar to me, and I just want to share with you a lot of the things that that I've learned over the years with treating these types of patients. I got to be able to teach for a while over at Western University to other therapists, learning entry-level doctors. Going out into the field, that was an excellent experience. And now I've been in Eisenhower for over 20 years, so it's been a great place to work. Going on to the next slide. So our objectives today, we're going to discuss the functional loss and what it means to quality of life. This is what happens with osteoarthritis, rheumatoid arthritis, things that destroy joints. We're going to present the concepts of why someone may need a total knee replacement. Sometimes it's not good timing. We'll talk a little bit about that. We're going to present the lower extremity anatomy and function, pre and post total knee replacement, overview of the knee replacement surgery, present prehab, which is kind of a new term in the last 5 years. It's talking about how do you get your knee ready for surgery. Those people tend to have really good outcomes because nothing's a surprise now. So you get it figured out how to get that knee ready for surgery and what it's going to be like so that you know how to handle yourself after surgery. And then the post-op rehab concepts, what do you do after you've had the surgery, and what interventions we do and how to get the best outcome. We're going to present possible placement options, like are you going to go to skilled nursing after, are you going to go home for home health, and talking about criteria that you want to look at for yourself on why you would choose either of those placements. And then present the possible outcomes after surgery. Sometimes it's good, and you've probably talked to friends. Sometimes they haven't had a good experience after total knee replacement, and we want to try to discuss how to get the best outcome possible. Go to the next slide. So why would you need a total knee replacement? Well, you may have had a history of trauma in that knee, car accident, a fall where you've fallen off a ladder, landed on your knee. There's just so many stories that I've seen you guys have had through friends where you've had happen to yourself. You've had a reconstructive surgery maybe in 1970, maybe in 1960, maybe 1980. As you've aged now, that knee's started to change. You've been a very active individual. So as a young adult, you've done a lot of sports, a lot of high pounding sports on the legs, runners, racquetball players, you name it. And you wore out the cartilage. Maybe you've been living a very comfortable sedentary lifestyle and you haven't challenged your knees physically like the athletes. Well, you didn't wear it out, but it wore out anyway. You have a disease process, rheumatoid arthritis, lupus, some of these things that affect the degeneration in your knee faster at a faster rate. The bottom line, it doesn't matter whether you've been highly active or not active, all knees eventually degenerate the longer you live. So it doesn't discriminate in regards to class, lifestyle, or good or bad person. If you're gonna have a worn out knee, it's a worn out knee. So I've had patients come in and say, oh my God, I shouldn't have done this to myself. I wore it out. I'm like, you did all those adventures. Did you love what you did? Yes, you did. Well, awesome. Enjoy that. It was destined to wear out anyway. And then someone would say, I never really challenged my knee. I had sedentary jobs, working in a cubicle and on a computer all my life. It's like, how did I wear my knee out? Well, you got a little older and your predisposition is osteoarthritis, so it wears out. It doesn't matter. So a lot of us get here no matter what. So the thing is don't beat yourself up that you got it. The thing is, what are you going to do now when you have it? And then there's just so many variables that affect the rate that you degenerate. It's just, it happens as it happens, and then you have to deal with it when it comes up. Go to the next slide. So why do you want the knee replacement? Well, the most thing people say is, I just want to be pain-free. And there's ifs and buts to that after knee replacement. Some people continue to have pain, but it's different. You want to continue to live an active lifestyle. Now, this is why people have joint replacements. You don't have a joint replacement to be sedentary. You typically get a joint replacement because you want to be active. You want to get back to playing pickleball. You want to walk your dog. It doesn't have to be athletic. You just want to go for walks. Your knee degeneration has gotten so bad, you're dreading getting in and out of a chair or a car because it grinds the bone on bone, grinds hard. You want to be able to get out of bed and ambulate around the house without pain. You want to be able to run errands, just going to the grocery store, you might get, or even just going to a restaurant, trying to be social, which hopefully we're getting back to, right? Those types of things. You want to be able to tolerate a day with family or friends. One of my patients, the reason he went to total joint replacement is he went to the zoo with family, and they had to push him in a wheelchair because he couldn't keep up because of the knee degeneration, and he wanted to keep up with the kids. And you know how they run around the zoo, like there's the elephants, there's the hippos, there's the whatever. He couldn't keep up, and being pushed around in a wheelchair, he's like, okay, that's the last straw. I got to get a knee replacement so I can keep up with these people and have this fun. So those are the reasons why people get knee replacements, is because the OA, the osteoarthritis, rheumatoid arthritis, the knee destruction is so bad, you can't function anymore at the rate to give you that quality of life. Go to the next slide. So reasons people get knee replacement surgery too soon. This is something to talk about where, a surgeon told you that your knee's so degenerative, you're going to need a knee replacement in the next 5 years. So then you get these proactive people that say, well, if I'm going to need it in the next 5 years, I'll just get it now. And I'm young and I'm healthy, I'll recover faster and da-da-da. Or you're about to retire and it's going to be cheaper for you to get the knee replacement while you're under health insurance under your employer than it will be afterward if you're 80/20 on Medicare or all these different other plans after you go on Medicare. You're younger and you feel that you have the stamina and the strength to tolerate the knee surgery recovery. And then your expectations might be, or why wait? I'm getting a new knee and that's going to fix everything. So the thing you got to watch out for with these types of things is if you don't have a whole lot of symptoms, you just have the signs of a knee, knee degeneration, bone on bone is starting to happen, but you're really not in that much pain and you really can function throughout the day with 1 to 2 out of 10 pain. Understand that what we're going to witness here when we go through further into the discussion is the amount of trauma that happens to you during knee replacement. Your brain, even though you're under anesthesia, when you wake up, people tell you that it's a painful recovery. Well, if your body perceived there wasn't much pain prior to a knee replacement and you get a knee replacement too soon, you may feel that this was the worst decision you ever made because you have so much pain afterward. Am I being clear on what I'm saying? It's like your body's perception of what's wrong is now accentuated because you remove part of the bone and you hammer in metal to get into this knee. So you can get a knee replacement for the wrong reasons. I've had a number of patients where they had minimal symptoms, they got the knee replacement, and now they have more pain after the replacement. And it's nothing that research backs up. This is just from experience, so it's anecdotal. These patients are now having more problems because they pulled the trigger on the knee replacement too soon. So that is a phenomenon that does happen. Doesn't always happen, but it does happen. So you want to get it do the right thing at the right time for the right reason. Go to the next slide. So, well, when should you get one? If the pain is severe when you're getting up out of bed and you're dreading getting to the restroom, You're fine when you're sitting, but after you've been sitting for a while, you go to stand up and it's severe pain trying to get up. The first 3 steps or 4 steps is agony, and then you start moving, it starts to warm up and get better. Your knee pain increases with running basic errands. You're dreading just going to Vaughn's to get some groceries because of what that does to your knee. When you're walking, your knee gives way uncontrollably, so you're at a risk for a fall. So now you're using a cane or a walker. So a definition, I don't know if you can see me there, but when you're walking and walking giving way is you're walking along and then your knee will just buckle. It'll just give way and you'll feel like you're heading down for a fall. That's what giving way is. When the bone hits the bone, the brain perceives that you're damaging it. So what it does is it shuts down the muscle. It won't let it contract. So then you start falling to the ground, but then your brain goes, hey, I don't want my head to hit the pavement. So it turns the muscle back on. So that's why the knee collapses, but then it turns back on and then you don't hit the floor. That's a buckle or a giving way moment. So if you're getting an increased frequency of giving way, increasing your risk for falls, heading towards having a hip fracture on top of, your degenerative knee, you want to get that knee replaced and fix that before you have a problem with that. If you're feeling off balance with basic ambulation, walking around, and you have increased difficulty ascending stairs or curbs, so especially people with degenerative knees know sometimes it's okay going up. The harder part is you're coming down off a step, and that's when that bone bites into the bone, and then you're going to collapse and have your fall there. Falling downstairs, not a great thing to experience for sure. The other thing you might be doing is you're taking anti-inflammatories, Aleve, or the other one, Advil, or you're on prescription naproxen or meloxicam or things like that to manage pain, and it's not helping. And now you're starting to get cortisone injections into the knee. So it's getting so bad, you're getting stronger and stronger drugs to try to keep the pain under control. If all of those things are happening, yeah, you're on your way and you're needing a knee replacement. Go to the next slide. So how does a knee work? This is just a picture of biomechanical vectors and trying to figure out how much torque's going through different tissues in the knee. We're not going to explain this. I just put the caption on the bottom. It's complicated, and knee is a very complicated joint. Go to the next slide. So how does a knee work? So patellofemoral articulation, patella, that's your kneecap. Femur, that's the bone on the top that the kneecap glides through. So there's a joint there. So that patellofemoral joint, it transmits forces generated by your quad muscle, which is the big muscle on the front of your thigh. There's 4 of them there, and that controls your tendon that attaches to the kneecap. So that increases the lever arm of the extensor mechanism, which is what that's called, and it decreases the extension force by 30%. So that pulley system is important for you to be able to control yourself from getting up off a chair, stepping down a step, and things like that. So the patellofemoral joint reaction force is up to 7 times your body weight with squatting. So when you start looking at the science of physics, you'll hear things like 7 times your body weight. Well, you're not lifting 7 times your body weight, but the load that gets produced through that joint is at that weight. So that's how much load goes through these tissues. So you wonder why they degenerate? That's because this is how much force they're going through for what? How long do we live now, right? 60, 70, 80, 90 years. So it wears out. Go to the next slide. So this is just a little chart to show you, like walking, you put 100 pounds of force through your knee. Ascending a stair, 660 pounds ascending. Descending, going down the stairs, 1,000. So that's why you feel harder stepping down. Jogging's 1,400 pounds of pressure. Squatting's 1,400 pounds, and deep squatting is 4,000 pounds. That's dropping your butt to the floor. It's a lot of load. Let's go ahead and switch to the next slide. So tibial femoral articulation, that's between your thigh and your shin. So you notice that as you bend your knee, your thigh is the top bone, that's the femur, and the bottom where the shin is, that's your tibia. So that's your tibiofemoral articulation. And that transmission of body weight from your femur through to your tibia or your shin. So that's the function of the knee. The tibiofemoral joint reaction force is 3 times the body weight with walking, 4 times the body weight with climbing. and then the motions in the sagittal plane. We don't need to know all that stuff. It's just showing you that there's a lot of load, again, that goes through both joints. So two main joints in the knee. Going to the next slide. So we looked at this at our last talk on, or one of the talks on walking, I believe, and one of the talks on strength. So this is gait speed. So the faster you can walk, like on the right-hand side on the bottom right, it says you can cross the street with normal speed, walking speed. If you're using a walker and you have a degenerative knee and you can't put a lot of force through it, it's going to slow down your gait speed. So people that are older that are now using walkers, they can be only a household walker because they can't walk fast enough to cross the street when it goes from red to green to allow you to walk across the street. These people tend to be more dependent with activities of daily living where people with faster walking speeds can do, they take care of themselves better. So what does this mean? If your knee degeneration is getting so bad where you can't run an errand, what you're fighting for now is not for high levels of athletic performance with exercise, you're fighting for independence. So if you're not able to run errands, now you're dependent on other people. This is the problem with trying to hang on to a degenerative knee too long. You start losing your independence. Going to the next slide. So when you look at the knee anatomy on x-ray, bone comes up white, cartilage comes up black. So if you look at the right knee, you see normal, and you see that nice black space between the two bones there, right in the middle where the arrow is pointing normal. And you look at the one on the left, there's your bone on bone. You see the white touching white? That's your degenerative change, that you've lost enough cartilage, now the bone's touching the bone. What's interesting about cartilage is cartilage has no nervous system. So if you cut open your knee and you took a knife and you started stabbing yourself in the cartilage, you'd go, so what? I don't feel a thing, because there's no nervous system to pick up pain in cartilage. If cartilage had a nervous system, when you jumped, when you pushed a door or something like that, you'd be in horrible pain because of the compressive force into the cartilage. The cartilage is that cushion that makes us pain-free when we do these movements. Bone, you know, if you break a bone, it's going to hurt. You're going to scream because there's nerves in the bone that let you know that you broke your bone. So the bone, when the cartilage surface that has no nervous system wears away and you're grinding bone into bone, there's your pain. And that's why you can't walk. That's why you get that protective mechanism and your muscle just shuts down and your knee gives way, and that sets you up for falls. So that's why the bone on bone is so bad, and you can see it on x-ray. Going to the next slide. This is between the kneecap and the femur. So you see again the top bone that looks like a big boulder with that black space sitting underneath that's got the little point on it. That black space is cartilage. We want that because the kneecap is gliding. Remember, when you do the deep squat, it does a lot of pounds of pressure. So if you have cartilage, you're good to go. Go to the next slide. What happened to the joint space? There's the patella, the kneecap, big boulder thing on the top. Underneath, where the femur is in the notch, there's a little bit of space on the right, but there's no space on the left. That's that bone grinding in the bone. And if any of you you go to get up and you hear that through your kneecap when you go from sit to stand, that's your patella femoral cartilage wearing away and you're getting closer to bone on bone. That's called crepitus. Go ahead and go to the next slide. So now when you get to, did we skip one or is that's it? Okay, good. So when you get to joint replacement, what you're looking at here is what's missing. So the bone that you saw before, you saw the space of the joint space. Now you see this very white material it's different than the bone itself, which is above that very white material. That's the metal. So when you x-ray metal, it comes up that clear. So these are different styles of knee replacements. So that's when you're talking with your surgeon, what's the best style for you? So they're cutting away bone and replacing it with metal. So these people are partial amputees because part of that bone is being removed and replaced with an inanimate material. Go ahead and switch to the slide. Yeah. So you're replacing your bone, cartilage, and meniscus, and you're also sacrificing your ACL ligament. So the ACL ligament is important for knee stability. but the way these joint replacements are designed, they're designed to create stability when they take away a stabilizing ligament. You can't put a knee replacement into a knee unless you get the ACL out of the way. Very good. Go to the next slide. So the other way to look at this too is you typically have metal on plastic. So you've heard of metal on metal replacements and having, you know, metal leaching into the body and with the hip replacements. When you're looking at knees, and you have to talk with your surgeon, because this is like computers. Every 6 months they get a new upgrade and the engineering keeps changing. So your surgeon's the expert on what's the best knee replacement for you. And a lot of them have a metal alloy on the top and a plastic material on the bottom. And like anything in life, you notice with the knees how they degenerate. If you take two materials and for 70 years you rub them together, they're going to wear down, right? So they're going to wear a groove into each other. So when you get metal on plastic, even though you've replaced the knee, if you're too young when you get the replacement, those materials also wear away. So then your knee can become unstable as some of the plastic wears down. So if you get a knee replacement when you're 30 or 40, that's unfortunate, because you're probably going to have to go to what they call a revision. They're going to have to do a new knee, maybe just a new component to give you a thicker plastic piece again because you wore it down. So that's why they always tell you, you want to wait as long as you can before you get your joint replacement, because you want the joint replacement to outlive you before you need a revision. Because if you get one and you're 50 and you need another one when you're 80, it's not fun getting a revision at 80. You want to just do this thing one time. Very good. Go to the next slide. So you want to discuss those different designs with your surgeon. How old are you? Are you going to be hiking on this knee? Are you just going to be sitting down, knitting, getting up, running errands, and coming home and working on your computer? There's better designs for how your bone stock is. So when the surgeon looks at what he's working with, they're the experts on knowing what type of knee replacement is going to be best for you. Very good. Go to the next slide. So warning, now what I'm going to do is I'm going to show you what you go through. So if you're kind of like seeing blood, human tissue being manipulated with sharp objects, now's the time. You're going to want to turn away, look down at your phone, look at something else. I'm going to let you know with these slides. So if you're squeamish, you don't want to look on the next few slides. So we're going to the next slide. All right, so we started off easy. So when you look at the before, there's a degenerative knee from an artist's conception, right? The cartilage is worn away, the bone is exposed, it's kind of bleeding a little bit because bone has a lot of blood. You look over to the right and there's the replacement. So you're seeing what gets cut away and what's getting replaced by that inanimate material. Go to the next slide. When you go into the surgery room for joint replacement, they look like mechanics and carpenters. They have a lot of sharp tools. They have hammers, they have saws, they have drills, they have these metal pieces that they're going to put in your body. They're prepping you for putting this stuff in there. Going to the next slide. So they have to set up measuring tools to make sure when they make cuts, these cuts are accurate. So your confidence in your surgeon, he's done this 1,000 times, he could do it in his sleep or her sleep, and they got to set up these measuring things to make sure that the angle is just right, because you're trying to match how a knee moves with man-made material rather than the nature-made material, which you've worn out over 60, 70 years. All right, go to the next slide. Then obviously we know with first incisions, when you cut, you're going to separate the skin, you're going to pull that apart, and you got to get down inside the joint. Go into the next slide. And they have to pull your kneecap off to the side, right? They have to put in material to make sure that when you guide that metal piece in, then it's going to get placed. So I wasn't kidding you. This is a serious surgery. There's a lot of tissue damage caused getting the thing in there. So you're wondering why, when you wake up after knee replacement surgery, you're having pain, your knee's horribly swollen, and it's not moving very well. Then you get to see us. Go to the next slide. So now what? They've cut this thing in, or cut you apart. They've dislocated your patella off to the side. They put the thing in there. They're going to sew it back up. Go on to the next slide. Everybody can look up now because we're out of the horrible slides. I put in the puppies and the kittens. So now it's safe to look. So now what do we do now? Let's go to the next slide. This is why when you look at the knee after the surgery, this is why it looks like this. Look at his knee on the right. Looks like a normal knee. You can't even see the kneecap here because he's so swollen from all the pictures that I showed you before. This is what they did to you when you were sleeping. So now when you wake up and you come to see us, it's like, wow, you know, why is my knee so stiff? I can't bend it. I can't straighten it. When I walk on it, there's pain. I feel like my knee's really weak and it's going to buckle. You know, why did I have this done? This is when typically people have a little bit of fear. They're like, what did I do? I didn't expect this, and da 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 da. Now that you know what's happening, you've got a lot of healing to get done before your knee starts it's gonna act how you want it to. Go ahead and go next slide. So common reports are my throat hurts. The reason your throat hurts is when they intubate to keep you breathing while they do the surgery. Then if you're going all the way under, that's why your throat hurts. That can last for a few weeks sometimes. Some patients complain when they come to therapy about that. I feel nausea and dizziness when I sit up. Well, they put so many drugs through you and it's such a shock to the body when you first sit up. Some people call it orthostatic hypotension. There's a lot of names for it, but it's a shock to the body. So it takes a while for your body to react to that. My knee hurts when I move it and it's really stiff. You saw the pictures or you didn't see the pictures. They do so much cutting and hammering and things like that. That's why. So be prepared for that when you come to rehab. Why is it so swollen? How long will it take to recover? A lot of people ask that. It takes about 6 to 8 months to recover. But every month that goes by is a month of healing. So it keeps getting better as you go through. It's not an all or nothing thing where, oh my God, my knee's swollen. And then all of a sudden I wake up, my knee's great. It's a process. My leg is really weak and I can't lift it. It weighs a ton. Yes, because when you go through all that trauma, your autonomic nervous system goes, hey, wait a minute, there used to be bone. Now the bone's gone and really swollen. Somebody was cutting me. Somebody was hammering. Everything's really swollen and sore. So then it inhibits the muscle from contracting. So that inhibition is what we work through with you in therapy is to try to wake those muscles back up. I want to go to the restroom, but I don't have the energy or the confidence to get there. So that's what we work through when you're inpatient in the hospital. Some surgeons are hoping that we can do this as a day surgery. So you go in and then you're able to just go home. So you have to look at how you are from, and they do too, how you are from a fitness level, and then can you tolerate a knee replacement as a day surgery, or do you have to spend 1 to 2 days in the hospital and look for replacement, either to skilled nursing or you go home to home health. Some people feel there's no way I can go home. How do I feel right now? We're going to talk about that later in the lecture. Do I need a walker, cane, or wheelchair? When you're in the hospital, they typically have discharge planning, so they help to set you up with that, with equipment and your needs before you leave the hospital. How do I shower? You probably talk with an occupational therapist when you're in the hospital, and they talk about, you know, how do you maneuver getting in and out. And that's using things like shower chairs, you know, because you may not be able to stand for prolonged periods, and there's a fall risk there. And then when can I walk normally? These are really common reports. Your brain's going, oh my God, what do I do with all this stuff? You want to figure this stuff out before so that there's no surprises when you get home. You got to have everything set up there. Go to the next slide. Yeah, go ahead.
Jonathan would like to know what's the best over-the-counter pain meds for joint pain?
So as a PT, it's not my scope of practice to give advice on medication. And that's the best question to ask your doctor. The reason it's a challenge is a lot of people have comorbidities, like they might be on a blood thinner. If you're on a blood thinner, you can't take NSAIDs because you're going to bleed more and you can cause a stroke or you can cause bleeds elsewhere. There's other conditions people have where NSAIDs aren't really good. They may have peptic ulcers, they may have other things going on, GI tract. So to say what the best is, one course I did go to, I'll share with you, that physicians were at, they talked about which NSAIDs were the best. And while the guy was talking, he kept throwing up different classes of anti-inflammatories. And his comment was, well, depending on the patient's body chemistry and comorbidities, one person may love Aleve, and another person it doesn't work at all. And on another person, Advil's the best, and another person, Advil doesn't work at all, and so on, from naproxen to meloxicam to any of these Celebrex, it just depends. So that's why you get frustrated talking to clinical people, because honestly, each individual person has a different response to medication and with their comorbidities, other things that are going on. So what's the best one? You're going to hate the answer. The best one is the one that works for you if you can actually take them. So I wish I had a better answer for you on that one. Really what you should do is consult with your physician. And then if you need to do trial runs, like say you do have a condition where you get inflammation and you can take an NSAID, you try an Aleve, then you try an Advil. Talk with your doctor about the best one. And if you find one that really works when you are inflamed, that might be a better answer for you because you've actually put it to the test and you know which one works better. Field testing is always the best. So short answer from all those other questions, it's going to take you 6 to 8 months to heal fully from a joint replacement procedure. Be careful. They tell you, oh yeah, so-and-so, he was playing golf in 2 weeks. There are outliers. There are people that literally do really well after this thing. As a PT, I would tell you after 27 years of doing this, I don't see a whole lot of those. And those kind of ruin it for everybody else because it takes so long to recover from all of the trauma and the surgery. People rush into things too fast, then they flare up, then they go to their doctor, then they come into PT, and it's like, we could have started doing this right before surgery. We didn't need to wait till after when you're all flared up and you have all these questions. So understand that every month of healing that goes by is you're going to progress forward, but you're going to have to gain range gradually. You're going to have to gain strength gradually. You're going to have to progress walking distance gradually. To do things like hiking, going up and off boulders and things, that's going to take time. It doesn't happen like that. It's a process. So you're going to progress typically from a walker to a cane to walking free if you were walking free before surgery. If you're walking with a walker before surgery, it's possible to get to an easier walking aid, but we'll have to see, what you have going on before we can make that assumption or try to progress there. So these are the challenge you have after joint replacement. Go to the next slide. So getting in and out of bed, this is something that is always a challenge. Your knee's going to weigh a ton. Your leg, it's going to be hard, and it's not going to like to bend when you come out. So typically the therapist is going to help gradually maneuver your knee to slide it out so that it doesn't drop, because your quadricep muscle is going to be so weak, it's hard to do that. So another one you can do, I don't know if you can see me over here, is when you're getting out of bed, let's say it's my right knee that's bugging me. So my strong leg is here. This one hasn't had surgery on it. So I can bring out here. Sometimes you can help it to bring it over, get to the edge, and then help it down and be careful with it like that. So you have to have of course, the maneuverability with your upper body and your lower body to pull that off. If you don't, and you're going to have a struggle with that, this is what helps you trying to figure out placement. Can I go home and manage myself? Do I need a caregiver to help me maneuver with that kind of stuff? Or do I need to go to skilled nursing? Because some of my 80-year-old patients are very challenged physically, and they need a team of people to help get them to recover so they can get strong enough so they can go home and be independent again. So that's the getting in and out of bed. Go to the next slide. So getting on and off the toilet or the chair, you're going to have to make sure, and this is another thing you can take a look at me here, that knee isn't going to want to bend. So when you're getting out of a chair, you might have to get a little better view here. If this is my operated knee here, this is my strong knee, I'm going to have to leave that knee forward because I'm not going to be able to bend it to just stand up. So I'm going to leave this forward, and then I'm going to have this, and I'll have my walker out in the front. I use my strong leg and my hands to stand myself up, and then I bring my operated knee back, and then I can start walking. Get yourself stable. So the thing to notice with with total knee replacements is early on, they're so swollen and stiff and sore, you're not going to be able to bend really well. Very good. Go to the next slide. So, right, so that's getting in and out of the chair. Getting in and out of the car is very similar. You have to twist yourself to where you see how she's facing out. You can't just plant your foot and twist out of the car you normally do. You got to square yourself up like that. And then you have to have enough range of motion to bend your knee to actually get into the driver's seat. So if you notice, I think it's showing her getting in the back seat, because sometimes when you're leaving the hospital, if you can't bend your knee enough, you got to slide your body back far enough to where you fit, because you can't bend your knee to get in. So when you're planning your transport home and you have a very small car, you're going to have to think of, how am I going to get in there? If you have the knee range to get into the passenger seat, then great. If you don't, then it's going to be a challenge getting home, because you got to be able to fit in. All right, go to the next slide. So can I walk after surgery? You're going to be getting up the same day of surgery or the next day, depending on the time of your surgery, your comorbidities and how you respond to anesthesia, how you respond to narcotics. People have had a lot of problems with that. But you are going to get up and you're going to stand on that knee and you're going to walk. So you got to be prepared for that. You may have a long leg brace on so that your leg doesn't buckle when you stand. You may not. If they do a nerve block, the muscle won't be acting, because it's going to feel like it's dead, because that's what the nerve block does. So you don't feel anything when you're under surgery. So it also helps with pain control for the first few days. So, but when they do the nerve block, the muscle won't contract properly, so your leg might just collapse. If you notice you have a long leg brace on, that's why you've had a nerve block. So you'll be using a walker for stability, and that prevents falls. They're better than crutches because they're easier, they're more stable. Some people do have crutches. I had one guy who was 74, he was still working on ski patrol. This guy was fitter than anybody I ever knew. And the day of surgery, he wasn't on a walker. He was on crutches, but his balance and body control was amazing. He skied his whole life. So that's an outlier, right? So I would use the walker. Walker's a whole lot safer. On your first walk, you want to be careful when you first get up. Are you dizzy or are you lightheaded? So if you're dizzy or lightheaded, that's when you're probably going to fall. So you sit up, and the therapist is going to work with you with that. You sit up and you wait. And if you feel lightheaded or even a little bit nauseous, that's usually the effects of the anesthesia. So just let the therapist know. Sometimes you get a little, you get a little sweaty, you get a little lightheaded, and you're like, oh, this doesn't feel right. It's like you might need to lie back down and then try it again. Sometimes it takes a couple of times. And when you feel that, you don't want to try to tough through that and start walking, because that's the 1 step, 2 step, 3 steps floor. You don't want to end up on the floor, and I don't want to have to pick you up off the floor. So if I'm getting you up the first day, I make sure that you don't feel this. So you want to be aware of that yourself. Remember, however far you walk away from when you get up for the first time and you're walking with the walker, you have to get back. So you got to make sure you save the energy. Don't walk to a point of failure where you're like, okay, I've walked enough, now I need to sit down, and you're middle of the place where there's no place to sit. So just remember to go short distances when you first start walking. You're naturally going to want to walk like a pirate who's in a wedding. And what that looks like is you take a big step, and then a little step, and then a big step, and then a little step. So like when you're watching those movies with those people in the wedding, and they take that 1 step, and then, that's why I call it, it's like your leg is straight like a pirate, and then you walk like you're in a wedding. So what we want to do is we want to try to not learn that behavior. You want to get a normal gait pattern early, because the longer you walk with a limp, you're actually going to learn that, and then it's harder in rehab to get rid of it. So that's what we want to do there. Going to the next slide. So what exercises will we be doing after surgery? These are the 4 big ones. You want to do it before and after surgery, actually, because these are the ones that get your leg ready for normal function. So I want to get up to here to where you can see me. So when you look at the quad set, when you come out of surgery, your knee's going to be bent. You've got to get this knee as straight as you can, as soon as you can, because if it gets stuck bent, a bent knee is a short leg. It's going to be shorter than the other side. So when you stick this under like this, you're going to make that muscle squeeze, and you got to see the kneecap. The kneecap will move upward. And as my kneecap moves upward, you see my knee is going down into the bed. I'm hyperextending my knee, not traumatically. All knees hyperextend a little bit. I'm using the towel to elevate my heel so that there's more space here so that I can drive my knee down to actually get that quad set and develop that quadricep muscle, but get that knee straight. You want to learn that before surgery and after surgery. That's your number one important thing to do. Going to the next one. And that's the heel slide, I believe. Yeah, so there's the knee. Oh, sorry, yeah, this is the knee straight. So you see how the knees are bent? It's off the table. This is the importance of the quad set. If you look to the right, see how straight the knee is there. But if you bend the knee, you shorten the leg. So you see these people limping around town with a bent knee. Those are people that didn't straighten their knee after their knee replacement. Go to the next slide. So those are the quad sets. Already talked about that. Go to the next slide. So there it is again. So you got to reactivate that quad. That quadricep's going to be inhibited from the surgery. It's not going to contract really well. It's going to be like it's dead. So you have to wake it up. And that's what we do when you're here at rehab, is we got to wake up that quad. If you don't wake up that quadricep muscle, that knee is going to get stuck. And if it gets stuck, you can't straighten it. It's permanent. So go ahead and switch to the next slide. So heel slides, this is using your hamstrings. They're also going to be inhibited, but you got to get your knee to bend also. So that's when you're on here. You take your towel and I'm doing the camera, I'm doing the talking. All right, so you're right here. So you want to have it frictionless, right? Now, what you'll see some people do is they'll bend up, be in pain, and then go back down. There's range there to get, and you got to try to get as much range as you can. So you bend it, and then you stop at the barrier where you feel the first pain. Then you bend it again to see if you can get a little bit more. It's going to be painful, but you'll notice there's more range. Then you bend it again. Then you bend it again. You try to get as much as you can till it won't go anymore, and then you let it back down. What some people do, they get caught up in this after surgery, is they just go, oh, I felt pain, I'm getting out of there. So they only work from here to here. Well, they're missing all of this range, and then it scars in, and then it gets stuck. And that's when you hear people go into manipulation under anesthesia. If you get too stuck, they put you to sleep, not all the way, just a little bit, and then the surgeon takes your knee and he really forces it through the scar tissue and breaks all the scar tissue, and then you come to therapy, and then we have to work it aggressively. If you work these heel slides really well, getting all that range yourself, you never ever have to do that. So if you teach yourself that before surgery, you teach yourself that after surgery, you get a better outcome and a lot less trouble going through rehab. Go to the next slide. Next one. Short arc quad. So when you do this one, this is another one you're trying to reactivate and wake up that quadricep muscle. So when you do that, you take a foam roll or you take a towel, beach towel, you wrap it up, get about a 6-inch diameter. This is the only time you get to put your knee on something like this. After surgery, this is the position of comfort. Patients put pillows under their knees, rolls under their knees. They try to relax like this because it feels so good. No, you've got to get that knee straight. So when you do the short arc quad exercise, you're going to notice how good it feels to just hang out here. The only time you get to do this is when you're doing an exercise to straighten your knee over the roll. And that's going to make you use that quad, wake it back up, make that kneecap move in that groove. So that's the short arc quad right there. Go to the next slide. There's a short arc quad. Next slide. Straight leg raise. So on this one, what you're going to do is this is a tougher one. You bend this knee to protect your back. You're going to squeeze your quadricep, push that knee down into the mat, just like the quad set. Then you lift the whole leg up straight, and then you lower back down. After knee replacement surgery, what you're going to feel and see is this quad can't contract very hard. So you're going to lift up, and it's going to drop a little bit. That's called a quad lag, like it's lagging behind. So as strong as you try, you're going to have a hard time locking it out straight. So you do the best you can, and as you get better, that leg's going to get straighter. But when you do your straight leg raise, remember to force it down straight, lift it up straight, lower it straight, then release it. Some patients will do this where they're trying to, I got to get as many in as I can, as fast as I can. That's going to end up hurting your back, giving you a cramp in your hip flexor. Don't do that. So remember to squeeze to flatten the knee, straighten the knee, squeeze, lift, straight, lower, straight, then release. Just let the leg relax. Set it up again, toe faces the ceiling, squeeze, lift, lower, release. And that's how you do a straight leg raise. Go to the next slide. There it is. So you're going to perform interval training for walking. This is how you progress your walking. You walk, we talked about this with the walking lecture and one of the other Zoom lectures, but start off, walk 1 minute, sit, rest for 1 minute. If you repeat this 10 times, you get 10 minutes of walking. As your inflammation decreases, your muscle performance is going to go up. So then you can gradually increase your walking interval from 1 minute to 5 minutes, 10 minutes. And then you want to get yourself up to that, anywhere from a 30-minute to an hour walk. So interval training, don't try to force walk 20 minutes in one shot. Go in little bursts, and then you'll get a better reaction there. Going to the next slide. So what exercises do I do before surgery? You perform the same exercises you'll be doing after. That's your prehab program. This is so you develop the muscle memory and the technique to improve your performance, so it's not a surprise after surgery. Progress walking intervals to tolerance, as it's difficult to progress an osteoarthritic knee. So you can try pool exercises to get yourself mobile, get your cardiovascular up. There's a number of hip exercises you should be doing because a strong hip is going to help you to control the knee and transfer better as well. Going to the next slide. So the hip exercises, we went through these with strengthening. So there's clamshells, hip abduction, monster walks, and mule kicks. So I'm just going to show you quickly each of those. And yeah, that slide was good as well, but just showing you quickly the clamshell. You lie on your side, knees and feet are stacked on top of each other. You lift the knee, keeping the feet together. You're going to feel that in the buttock. So that clamshell is going to build that buttock muscle that you need for transfers and balance. The hip abduction exercise, the leg is straight. You turn the toe down this way a little bit, and you lift the leg up and back. Do not lift it forward. That's your hip flexor. We don't want that. We want to work the butt muscle. So you're going to roll that pelvis forward, leg stays straight, and you come out to the back and you do this. So that's the hip abduction exercise. And then the monster walks. If you can tolerate them, you take a TheraBand, and what you do is you wrap the TheraBand around the legs and you tie it. TheraBand you always tie in a bow, because if you tie it in a knot, you'll have to cut it off. And then what you do is you go sideways, stepping sideways like this with the TheraBand. It helps to build your butt. So that muscle you'll need there as well. And that'll help your knees post-rehab. What's the other one I missed? I know I go back to the other slide. So, and the mule kicks, yeah. So that one looks like this. There's just so many, and each patient, sometimes you do different ones. So you can see me there. Nope. So there you want to be leaning forward, supported here, and then you bend the knee and you lift the hip, you lift the knee upward like that to get this here. You're going to feel this leg, the one you're standing on, that's going to be working as well as the one that's doing the motion. So you're not doing a fast karate kick out to the side. You just a bent knee and you lift the heel up towards the ceiling, getting support with the hands on the upper body on a stable object. And you're going to feel burning in the muscle on the stance leg. You're also going to feel burning in the muscle on the buttock, because those are the muscles you're using to build up that hip and stability there. Next slide. So those are the hip ones. And then placement after. These are the questions you need to start thinking of before you get a knee replacement. Do you live alone? What kind of support system do you have? What's your home like? Like support system, you know, is there family members there? Is there friends or neighbors that are willing to be there for you when you need them? What's your home like? Are there stairs? Is there an elevator? You're in an apartment. How far is from the bathroom to the bed? What's your tub and shower like? Can you walk in? Is there room for a shower chair? If you're in the hospital, if you can't walk from the bed to the bathroom and back without feeling dizzy or feeling like you're going to fall, then you need to be in either skilled nursing or an acute rehab hospital to regain your strength and your function so you can get home. If you're not thinking of that before you go in, you're going to wake up with the swollen knee and you're not going to be able to walk to the bathroom. And they're telling you, well, in the next 2 days, we got to place you somewhere. It's like, oh, I didn't know about that. I just want to go home. But if you can't get in the hospital by yourself with supervision from the PT to start, if you can't walk get yourself out of bed without us lifting you, and you can't get from there to the bathroom back, what's going to happen when you get home? You're going to be in bed, you're going to not be able to get up. So then it's a 911 call, and then you come back to the hospital and figure out to place you in skilled nursing. So you have to you have to do well enough to be able to function to get a placement to go home. So that takes away the panic, it takes away the scare. Know your abilities and that. If you know you're going to skilled nursing, try to establish with a skilled nursing place you've checked out that you like, rather than going to one that is strange to you. Going to the next one. So after surgery, if you can't walk from bed to the bathroom, without feeling dizzy and whatnot. So that's, you're gonna either need skilled nursing or acute rehab. Why? They have a staff to help keep your room clean, feed you. There's help with personal hygiene and toileting to prevent falls. They have rehab staff to help you gain strength and function, return home, and decrease your risk for falls. So that's what happens at skilled nursing or acute rehab. Next slide. And then home health after surgery. If you can walk from the bed to the bathroom, you can go around the nurse's station without feeling dizzy or feeling like you're going to fall, then you can go home health. So at home, you're going to need a walker and a cane as you progress to independent ambulation. You're going to need raised toilet seats, because if the seat's too low, your knee's not going to be able to bend very well to do that. You're going to need a shower chair to help you with showering, and an extended, like a telephone attachment, I always call it. It's the one that you can spray yourself down, because there's that attachment where you can bring the shower head to you. That helps when you're in the shower chair. And then you're going to want to regimen yourself to get up for, like if you're in skilled nursing, you got to get yourself up for breakfast, lunch, and dinner. You got to do 2 workouts a day, one mid-morning, one mid-afternoon, to get that knee straight, work on the knee bending, work on the quad, work on the hamstring. If you're in rehab, that's what they do. They get you on that schedule. If you're at home and you're going to sit at home with a pillow underneath your knee, you're not going to get a good outcome. And these are the ones that complain about the surgeon, to say the surgeon screwed up their knee. And it's like, you've got to get that knee mobile and get moving. You don't lie around waiting for the pain to go away. This is the frustrating part about knee replacement recovery. You've got to push through some of that pain to get your knee as mobile as possible to get the best outcome. It's about the rehab. Going to the next slide. So outpatient PT, depending on how you perform after surgery, it'll tell you how well when you'll be referred to outpatient, and why even after a month, you're still going to be swollen, stiff, and weak. You'll be an outpatient for sometimes up to 2 months to try to get a lot stronger with ascending, descending stairs, working on balance, getting away from your knee buckling, giving way, things like that, just from weakness from having had the surgery. And you'll be working on correcting the gait, getting rid of the limp, gaining range of motion, full bend, full straight, and strength for all of those functions. You're going to be working, on balance. And like if you're trying to get back to pickleball, we have to work on pickleball agilities. If you're getting back to hiking, we have to work on hiking movements, things like that. So depending on what you're trying to get back to, that's how we gear the outpatient program to get the knee doing that. Even had a guy used to do old-timer hockey. We had to get him back on skates. How long does it take to fully recover again? 6 to 8 months for a full recovery. Remember, every month that goes by is a month of healing. It gets better. You will recover more efficiently if you stop putting pillows underneath your knee. Don't do that. Get your knee straight. Do your exercises. Your outcome is only as good as how you perform your daily routine. Get your knee straight in the first 2 weeks. I think I said it 18 times. I'm going to say it again. A bent knee is a short leg. You want to walk, you'll be walking like you have 1 foot in the gutter if you have a bent knee. You're not going to like that. Don't kneel. All my Catholics, people that kneel, God understands. It's not a joke. You don't want to be kneeling on a total knee because you've interfaced metal with bone. You've got two materials and you're creating a shearing force. If you work that component loose, you got to go for revision. Don't kneel on total knees. Use a walking aid to prevent falls until your strength and balance are adequate. Some people don't want to walk or cane because of a stigma or how they think they look. Don't fall, because if you fall and fracture, those are nasty when you get a post-op knee replacement or hip replacement and then they get a femur fracture. Don't do that, please. You can't go from 0 to hero in 2 weeks. You're going to hear stories. Yeah, there's some guys out there and ladies out there that maybe are outliers. It's not the norm. Take it slow so you get the best outcome. Switching to the next slide. You're now knee experts. Holy cow, thanks for hanging in. You saw, hopefully this information was helpful. I hope this helps you to plan ahead. Think about the timing of your surgery and life events. I've had people had to cancel trips to Africa and safaris because they thought they would just get a total knee replacement in a couple of months, they'd be ready to go. So think about what are you doing after. So weddings and things like that, people have put it too close and they're not recovered enough to walk down the aisle and that kind of stuff. So these are just stories I'm sharing with you that have happened with patients I've seen. Not all people are zero pain after surgery, so consider this before you make the decision. Sometimes people have pain from hardware. It's a thing that happens. So that's why I say make sure your knee is so bad that you're crying for the surgeon to do the surgery, because it's so bad, anything he does is going to be better than where it is. If you have no pain or minimal pain going in, these patients I've had, they don't like the result because their perception of what their knee felt like before wasn't that bad. Now it's bad because they've had bone removed and metal hammered in. So if you're bone on bone grinding and it's horrible, those patients love their surgeon and their knee replacement because they go, oh my God, I feel so much better and I can walk. So timing is everything on that. Ask other people who have had this surgery and what their experience was. You're going to get a plethora of responses. Great, horrible, mediocre, da-da-da-da. And I can tell you after 27 years of doing this, I can say doing the right thing at the right time for the right reason usually gets you the best outcome, and doing your exercises. Next slide. Thank you.
Woohoo!
You guys hung in there. That was a lot, huh?
You hung in 3 minutes past, so I appreciate everybody. I'm exhausted. I don't know about everybody else on this thing, but I'm exhausted. I don't want to ever have to do all those exercises. I've got a little crunchy when I'm going up the stairs. My knees make that nice little crunchy sound. I'm just going to learn to love that crunchy sound and try to just keep it the way it is, because I'm telling you, that's a lot of recovery.
It is. So when you don't know that, and what I'm trying to share with people tonight is if they don't know the expectations, sometimes psychologically after, they're devastated because they're shocked at the amount of recovery that's ahead of them. The ones that know, they're ready to roll because there's no surprises. They know exactly what they got into and why they're doing it. And like that guy with the family with the zoo thing, he didn't want to be in that wheelchair getting pushed around. He wanted to be running with the kids to the next thing. So he was highly motivated for his surgery. So the reason for all of this data for you is hopefully the more educated, knowledge is power, now what it's going to be. make the right decision at the right time.
Save the knees. Save the knees.
There you go.
Well,
Anybody
thank
got any questions?